Okay, guys, rolling right into that intra-abdominal arterial evaluation. So some of this is going to be a little bit of a review from the spring semester when we learned about abdomen with Dopplers, but we're also going to spend a little bit more time talking about performing a renal artery stenosis exam. So some of this information will be new, some of it will be review. Of course, with anything in the arterial world or the vascular world, again, like our peripheral evaluation, we have capabilities and limitations. Very, very similar to what we just talked about on the previous lecture, but there are some additional things in terms of what we're able to evaluate within the abdominal cavity. So renal artery stenosis, this is going to be an exam that we perform to evaluate for uncontrolled hypertension. Our kidneys have a renin-angiotensin kind of give and take relationship that has a direct effect on our blood pressure. So our kidneys and our cardiovascular system are very closely related in that sense. So when a patient has high blood pressure and hypertension that they can't control with medication, they have to kind of figure out why and what's going on with that patient. So we always look at the renal arteries to see if they're stenosed. If they are stenosed, that is going to have a secondary effect on why that patient is going to have high blood pressure. Also, we can evaluate for TIPS, which we'll talk about today, organ transplants within the abdominal cavity. And again, we're a great study for any patient who has a contraindication for having contrast with an MR or a CT exam. Limitations, of course, obesity, bowel gas if our patient isn't fasting, any kind of surgical scars on their abdomen, and if our patient cannot hold their breath. That is essential for abdominal Dopplers and renal artery stenosis exams. So if they can't hold their breath or they can't take deep breaths in, then unfortunately it's going to be a limited exam. Going into our renal artery evaluation. So within the US, we have 20 million patients that have hypertension. Half of these patients are going to be caused by some kind of kidney association, whether they have chronic renal disease, renal artery disease, or renal vascular hypertension. So half of these patients with hypertension in the United States are going to have some association with the kidney. That's a lot. And that's kind of like an unknown thing. Like a lot of people don't really know that our kidneys play such a role in patients who are on high blood pressure medications or need to go on high blood pressure medications, or maybe why their medications aren't working. So it's a pretty staggering statistic. The cause for a kidney-associated hypertension diagnosis is usually going to be when we have atherosclerotic plaque within the renal artery. So typically in the proximal origin of the renal artery is where we are going to see plaque starting to accumulate. Now remember from last semester or the spring semester, proximal artery, renal artery, is going to be closest to the aorta. You're going to see some techs, we'll talk about this again in a little bit, but you're going to see some techs when they're performing a renal artery exam call the renal artery proximal when it's closest to the hilum of the kidney. That is incorrect. That is the distal part of the artery. Our arteries originate closest to the heart. So the proximal region of the renal artery is going to be right where it comes off the aorta. The distal region of that renal artery is going to be when it enters the hilum of that kidney. Sometimes I like to just, for confusion's sake, I like to make sure that I call proximal renal artery the origin, right? Because that's where it's originating from. It's originating from the aorta. I call the mid region mid, and distal I call the hilar region. So they know I'm looking at the hilum of the kidney for that distal aspect. So we'll come back to that again in a second. Also, some patients can have fibromuscular dysplasia of the renal artery. This is usually really only going to occur in female patients, and it's kind of where that renal artery has this abnormal muscular contraction that's happening to it, kind of in a constant state. So that's why they have hypertension, because it's kind of always in this like narrow stenosed state from that fibromuscular dysplasia of the renal artery itself. And then also anyone with an aortic dissection. So anytime we have the aorta literally being sliced in half from that dissection, we're not going to have abnormal supply of that arterial blood to the kidneys, and it's going to result in hypertension because of it. So renal vascularity, kind of just recapping some of this here, our main renal arteries are going to branch from the aorta slightly distal to where the SMA is going to come off. Our right renal artery is going to travel posterior to the IVC, and it's going to be a little bit longer than the left renal artery because it has to travel further to get to that right side. It has to travel behind that IVC. It has to kind of travel and account for all the distance that the liver takes up. Our left renal vein is going to travel anterior to the aorta and posterior to the SMA. So we're going to see the left renal vein kind of be sandwiched in between some arterial vessels. So it's going to be sandwiched between the aorta and the SMA. So if we look at this picture here, our SMA is going to come off right here, and then that left renal vein is going to go between that SMA and the aorta to dump back into the IVC. So our left renal vein is going to be longer than our right renal vein. Right renal artery longer, left renal vein. And if you look at this diagram, it's pretty straightforward. You can see why. Moving into the actual vascularity within the kidney itself, we know that we are going to be supplying the kidney with our renal artery. That renal artery is going to branch into segmental arteries. Those segmental arteries are going to branch into interlobar. Those are going to branch even further into arcuate, and then even further, so all the way out at that very far cortex, we're going to see interlobular arteries. Those are going to be the last artery that we have that is going to be communicating with the capillary beds. And then from there, we're going to have our venous exchange. So the capillary beds are going to drain into the interlobular veins. Those are going to converge together to form the arcuate veins. Those are going to converge together to get even bigger and form the interlobular veins. Again, those are converging with themselves to form the segmental veins and then out through the renal vein. So the arteries, they start bigger and get smaller. And then the veins, they start small and get bigger as they join together to drain out that kidney. So how do we evaluate a renal artery stenosis or the vascularity of that kidney in a patient? So like we said, the main purpose of performing this arterial Doppler exam is to find a potential cause of hypertension, specifically uncontrolled hypertension. It's also to prevent renal failure due to any kind of permanent changes in that functional tissue. So if a patient has any kind of kidney disease, we want to make sure that we're evaluating the severity of it so that we can help that patient prolong the longevity or the lifespan of that kidney. We're also evaluating for kidney transplants. We're looking at that renal artery for any kind of abnormal position, twisting, any kind of kinks in that renal artery, any narrowing of that renal artery, and if there is a kidney transplant rejection. So we're relying a lot on the vessel integrity to see if a transplant is sticking or if it's being rejected. And then we also can evaluate that renal vein for thrombosis. Of course, we never want a thrombosis because the last stop of the renal vein is right into the IVC, and that can travel right up to the heart. So protocol for this, we're doing a routine kidney exam. We're looking, for size measurements. We're looking at the, echogenicity. We're looking at the shape of it. So we're looking for variance, pathology, standard routine kidney protocol. We're then going and looking at our aorta. So right at the level of the SMA, we want to be taking a peak systolic velocity measurement of the aorta. We also want to look and see where those renal arteries are coming off that aorta in a transverse plane. So we are trying to get our aorta like this, and we want to see the transverse renal arteries coming off them like this. Sometimes they'll kind of come off like this, when we're in transverse. We want to have transverse aorta, and then we want to see the branching coming off each side. That's going to show the origin of those renal arteries. We also want to be taking a peak systolic velocity and an end diastolic velocity measurement of the main renal artery in the proximate distal segments, and then also the segmental arteries in the upper, mid, and lower. There are some protocols that require us to go even further into the kidney. So some places you'll see that they try to go into the arcuate arteries, so a little bit closer to that cortex of the kidney. Basically, as far into that cortex as you can accurately see is where we should be evaluating. So how do we interpret what we're seeing with this? Well, we know our renal arteries are going to be low resistance vessels. The aorta is a high resistance vessel, right? It's that kind of like weird hemodynamic relationship of the aorta. So we have a low resistance vessel that is coming off of a high resistance vessel. So we're going to take a ratio of those differences. We're going to do a renal to aorta ratio, so an RAR. You're going to see that a lot with this exam. It's where we take the highest PSV of the renal artery, so regardless of where it was, could be proximate, distal, renal artery, whatever the highest velocity was, and we divide it by the aorta PSV. So right where we took that peak systolic velocity of the aorta, kind of near that origin, just underneath the SMA, is where we're going to calculate the two. If we get less than 3.5, right, so the difference between the aorta and the renal artery is not super, super high, it's going to be considered normal. If we get anything that's greater than 3.5, it's going to be abnormal, and anything greater than 4 is still going to be abnormal, but it's going to say to us, okay, whoa, this vessel is like really stenosed. We're getting at least a 60% diameter reduction with that from this ratio. So significant stenosis in that renal artery, again, should be seeing post-stenotic turbulence. We should be seeing a mosaic pattern of that artery, and we're going to see really high elevated PSVs in a stenosis. Again, kind of elaborating more on what we use in terms of our measurements and our evaluation. In addition to an RAR, we're also going to do an EDR and an RI. So these are going to be talking about kind of how much blood flow the kidney is letting into the tissue. So end-diastolic ratio, this is where we're taking information from the vessels within the kidney themselves. So the RAR, we said we're taking the aorta information and the renal artery information, and we're making an impression with that. But now we have to look at what's going on within the actual kidney itself. So an EDR is where we're taking the end diastolic velocity and dividing it by the peak systolic velocity from the segmental artery. So within that segmental artery, we know we're going to be in the kidney tissue. We're taking that waveform, we're getting a PSV and an EDV. We're dividing the we're dividing the EDV by the PSV. Anything greater than 2 is going to be normal. Anything less than 2 is going to be abnormal. So we're saying, okay, how much resistance, or really not really resistance, but how much blood flow are these segmental arteries letting in that particular region? Now, how much resistance, how much of a fight is this kidney putting up to the vascularity in that area? How much resistance is this organ causing to the vessel? If it's really high resistance, then it's saying, okay, I'm not letting a lot of blood flow through, and that's a problem. This organ needs blood flow. I need to have a low resistance because I'm a soft tissue organ. I need to be getting blood flow to my tissues. And for some reason, I'm like putting up barriers. So we want to see really low resistive index numbers. So to calculate a resistive index, still using the segmental arteries, or really, whatever your site protocol is, but we're still using the waveform from the vessel within the kidney. We are taking the PSV, we're subtracting the EDV from it, and then we're dividing that number by the PSV again. Anything less than 0.75 is going to be normal. Again, we want a low resistance number. We need a lot of blood flow getting through those tissues. Anything greater than or equal to 75 is going to be abnormal. And an abnormal aspect with this is always going to say, okay, it's too high resistance. We need to figure out why this tissue is not allowing the blood flow in when it should be. So you have some examples here that you can kind of just calculate and see if they would be considered abnormal or normal. And then the other thing that some places are doing in terms of their protocol is they're adding in an acceleration time. So this is the amount of time that it takes from systole to get to the peak systolic velocity. We want to see very, very fast acceleration times. So anything greater than 300 centimeters per second. And we'll take a look at what all of these kind of look like on our next slide here. So here on the left-hand side, we are getting information that we can use for an RAR because we are Dopplering the renal artery. This image annotation is incorrect. And I'll kind of give, kind of pause and take a second and see why the annotation is incorrect. And it's because it's calling this the renal artery at the origin. And we literally see that it's right next to the kidney. So this is not proximal renal artery. This is not origin renal artery. This is distal renal artery, right? Because we're at the hilum of the kidney. So all things to be aware of and things that are very common for techs to kind of mix up. So here, other than that, it's a beautiful picture. We are Dopplering the renal artery kind of in that distal region at the hilum. We're getting a peak systolic velocity measurement here. And then we're also getting an end diastolic velocity measurement here. So the only thing that we truly care about in this region is going to be this peak systolic, and then we're going to add that in combination with the aorta information to get our RAR. Now we're moving to the picture on the right-hand side. So now we're looking at the segmental arteries. We're within the kidney itself, so we're getting a little bit more definitive information. We're going to be able to get an end diastolic ratio. We're going to be able to get a resistive index, and we're going to be able to get an acceleration time. So we're getting a waveform in that segmental artery. We're going to be getting a peak systolic velocity, and then we're going to be getting an end diastolic velocity, and then we are also going to be getting an acceleration time. So our peak systolic velocity here, end diastolic here. We can use those to calculate our EDR and our RI. And then our acceleration time, if you look at the beginning of this waveform here, so look at these like little yellow dotted lines. We're measuring from the start of this contraction all the way up to that peak systolic velocity. And see how they're very, very, very close together? That's great, because that's saying that it gets to that peak systolic velocity really fast, like almost instantly. So if you look at our measurements on the screen, it's saying that the acceleration time was almost 700 centimeters per second. That's really fast. So that's really good. We want to see that. When we don't see that, that's when we're going to be questioning for tardius parvis. So this is basically saying that there could be a potential stenosis in this area that's not allowing that blood flow to reach its full potential. So this is when we have a very slow acceleration time. We have a very low velocity. Everything's kind of weakened, but we're still getting like kind of an arterial waveform. So tardius parvis is literally saying late peak, low velocity. And we know that this is going to be caused by a suspected stenosis. So here, if we were to measure this, we would have a very low peak systolic velocity here. And then at the start of this contraction, it starts over here. So the time that it takes from the start of that contraction to get to the peak systolic velocity is going to be significantly slower than what this one was, right? Look how drastically fast it gets there, whereas this one takes more time. And here we just have some nice, pretty images for you to kind of see that renal artery and sagittal. That picture on the left-hand side is just like so absolutely beautiful. I love this picture. I will use this picture every year, every single year that I teach this class. It's just fantastic. And then transverse, this is kind of what we want to see at that origination with the aorta. We see our right one right here, and then we see our left one coming off. Okay, so moving on to how we evaluate if a patient has a renal transplant. We should remember that if you have a transplanted kidney, that your kidney is not going to be placed in the same spot. It's going to be placed in your pelvis. So we need to be aware of that in terms of our scanning technique. So we know that these are going to be located in the pelvic region. The connection between the vascularity of a transplanted kidney is a little bit different because we're putting it in the pelvis. So we're putting the renal artery in connection to the external iliac artery or the internal iliac artery. Typically, we're going to connect it to the external iliac artery just because it's a little bit bigger. Internal iliac artery is a little bit smaller, so it's a little bit more likely to not work. The renal vein is going to be connected to the external iliac vein. So a transplanted renal artery and renal vein are never going directly into the aorta and the IVC. It's too much of a drastic change. We kind of need a little bit more real estate for that vascularity to kind of hang out for a second before it joins up with a major artery or a major vein. We also know that we can use living or cadaver kidneys. So, if a patient unfortunately passes in a car accident or what have you, they can use those as cadaver kidneys. And then you can also donate a kidney if you are a match for another living person. Post-op evaluation, we want to be looking for any kind of surgical complications. So the standard hematoma, seroma that can occur with any kind of surgery. We're going to be looking for hydronephrosis to see maybe, there's a little blockage from surgery in that ureter. And we want to be looking at the parenchyma. So the tissue appearance is going to be very important in terms of determining rejection. When we are rejecting a kidney, the tissue on ultrasound is going to become very, very echogenic, and it's going to become very large. With that, we're also going to see decreased color flow, and that's going to be indicative of increased arterial resistance. So we just said we want our kidney to be low resistance, but for some reason, if our kidney is rejecting, it's saying, okay, well, nope, that's it. I'm not trying to get anything else. I don't want any of this arterial supply. I'm not letting any of this in. And therefore that kidney is not going to be getting the necessary blood flow that it needs to stay alive. So we're not going to see nice color perfusion. We're going to see really increased arterial resistance if we do get a waveform that we're Dopplering. And then in order to definitively confirm that the kidney is being rejected, we do a biopsy to kind of see what's going on with that tissue on a cellular level. If there's tissue necrosis when we do that biopsy, well, that tells us that that kidney didn't take and it was rejected. So pretty unfortunate that you would think that with modern medicine, we'd be able to find out a way to really kind of prevent organ transplant rejection. There are a lot of anti-rejection medications that people can take, whether it be, kidney transplant or a liver transplant, heart transplant, but sometimes you just never know. So now moving away from our kidneys and moving more into our abdominal evaluation, we know how to do standard abdominal Dopplers, right? We do our main portal vein, our hepatics, left to right portal vein, hepatic artery, splenic vein. We know how to do all of that stuff, but there are also different arteries in that ballpark that you probably haven't seen performed at clinic. These are not exams that are standardly performed because they're not super accurate with ultrasound, and they're very, very hard to begin with. CT is going to be the modality of choice when it comes to evaluating some of the mesenteric vascularity. So if we need to evaluate the SMA further, if we need to evaluate the IMA further, CT is going to be the first stop for that. Now, the purpose of looking at our mesenteric arteries is to help diagnose mesenteric ischemia. So our mesenteric arteries are going to go to kind of supply a lot of our gastrointestinal system and a lot of our supportive peritoneal structures. If for some reason these vessels are stenosed or they're blocked, the bowels, the mesenteric tissue, everything located in the mesentery is not going to be getting blood supply. So our bowels aren't going to work properly. We're going to have a lot of pain, a lot of discomfort, a lot of complications. So although we don't really evaluate these commonly, it's not to say that this isn't a big thing in healthcare. So if we were to be performing these exams, we need to be aware of some of these things. So mesenteric ischemia is going to be very rare because we do have a lot of collateral pathways within our abdomen. So true mesenteric ischemia is going to be rare. Typically going to be caused by atherosclerotic plaque getting lodged in these small arteries. Our celiac, SMA, and IMA must all three be positive for mesenteric disease in order to get a true diagnosis of bowel ischemia, because of all of the collaterals from these vessels. So if our celiac access is blocked, if our SMA is blocked, and our IMA is blocked, then our bowels aren't getting anything, right? Our gastrointestinal system is not getting any blood supply, and that's a very emergent situation. Now, if the IMA and the SMA are blocked, but the celiac access is still good, we know that we can get blood supply sent to our bowels by that hepatic artery or that gastric artery or that common hepatic artery coming from that celiac access. We know that we can get a collateral from one of those vessels. Same thing, if our celiac access is blocked and our SMA is blocked, well then our IMA is going to work overtime to compensate for that. So if 2 out of the 3 are affected, we're still going to be concerned about that, but it's no longer going to be bowel ischemia, it's going to be chronic mesenteric ischemia. We really can have chronic or acute conditions, within this ballpark, kind of on a very individual basis. Acute Mesenteric disease is usually going to be caused by plaque embolization. So we have plaque somewhere else in the arterial system, travels into these smaller vessels and gets stuck. The main complaint that we see with patients that we're trying to rule this out on is going to be postprandial pain. So these patients will basically starve themselves unintentionally because the pain that they experience after they eat is so severe that they develop a fear of food syndrome. They literally become traumatized by eating, and that's how intense this can be. So their digestive system is really, really, truly affected. It's truly not working the way that it should be because it's not getting the necessary blood supply. These patients also suffer from severe cramping, diarrhea, bowel changes, significant weight loss because, again, they're afraid to eat because of that postprandial pain. How can we evaluate this? Again, this is kind of like an anatomy recap here. Our mesenteric arteries, like we said, supply our digestive system. Our celiac axis is going to be considered a mesenteric artery. It's the most proximal, I guess we could say, artery out of the system. So it's the most cephalic, located closest towards the patient's head. It's going to divide into that hepatic artery, splenic artery, and gastric artery. Our SMA is going to be located slightly inferior off the aorta to the celiac. It's going to supply our duodenum, small intestine, and colon. Our IMA is going to come off the aorta below the level of the SMA. And below the level of the renal arteries as well. It's going to supply our transverse, descending, and sigmoid colons. And then we also kind of have like this other accessory mesenteric artery. It's going to be our pancreoduodenal artery, and it's going to feed exactly what the name says. So it's actually a branch of the gastroduodenal artery, and it's going to allow for communication between the celiac and the SMA. That's kind of showing how that collateralization of our abdominal vasculature works, right? We have these little arteries that can communicate between each other. So evaluation of our mesenteric arteries, like we said, we want to be looking at our celiac, our SMA, and our IMA. Those are going to be the big culprits. Within the celiac, we also want to be looking for that common hepatic, that splenic, that gastric artery. Those should all be low resistance vessels, right? Because they're saying, hey, I'm going to supply a soft tissue organ, a major organ that needs a lot of blood supply. So I need those vessels to be low resistance. I need to allow a lot of blood flow to travel through. Our SMA and our IMA, these are going to be variable. So whether our patient is fasting or whether they've just eaten, that's going to change the amount of resistance in those vessels, right? If you're fasting, you're saying, okay, you're fasting, you're hungry, right? Your system's kind of like, oh my gosh, when am I getting food? When am I getting food? When am I getting food? When am I going to have to work, right? I don't know when I'm going to get food, so I'm not really going to allow a lot of blood flow to travel through. I'm going to kind of put up a barrier until I know that I need to work, right? Because I don't want to waste my energy while I'm waiting for this patient to eat or I'm waiting for this human to eat. Now, our patient eats, and it's like, whoa, I need a lot of blood supply. I need help digesting this food. So I'm going to become low resistance to allow all of this blood flow to travel through to the bowels to help get that food digested. Now, the protocol for these, you want to do these in a fasting state and then also in a postprandial state. So you have to be aware that your patient is probably going to be very uncomfortable once you have them eat something, right? It's an unfortunate situation, and it's kind of why we don't perform these exams routinely. Now, the fasting portion of the protocol, we want to be getting a PSV and an EDV of all of these important mesenteric arteries, so the entire celiac axis. We're trying to evaluate the SMA in a proximal distal sense, but as we know, sometimes even on like a super thin, no gas, like great patient, we're still really only seeing the proximal SMA coming off the aorta. Mid and distal SMA is really, really hard, especially in a patient that's maybe gassy, maybe has a little bit of a thicker abdomen. It's tough. And then on top of it, we have to also look at the fasting IMA. So if you have a patient who maybe has got like 20, 30, 40 extra, little pounds hanging out on them, you're never going to see the IMA. You might see the IMA in a patient who is 100 pounds soaking wet, but even that's not going to be a guarantee because it's located posterior to all of that gastrointestinal anatomy. So it's located behind all the small intestine, all that bowel gas. We're probably not going to accurately see the IMA, but apparently, according to this protocol, we have to. And then we're also looking at our aorta, getting a PSV and EVV of that. Once we have all of that information, we give our patient a very high calorie drink, typically like an Ensure or something that has a lot of caloric substance to it, but isn't going to produce a ton of gas in the patient. We need to document the amount of the fluid that they drank, the symptoms that they have after drinking, and then the time that we're performing the postprandial pictures. So we're typically waiting 20 to 30 minutes after they have that drink. And then we're going in and we're looking at the SMA, again, proximate and distal. And if you can see the IMA, then you're also looking at that postprandial as well. So evaluation of this, how do we interpret all of these mesenteric vessels? What are we looking for? What's normal? What's not? So again, it's going to all depend on pre versus postprandial state. For the SMA in the preprandial normal patient, we should see high resistance flow with a little bit of diastolic flow reversal. That's totally fine if it drops down below the baseline just for a quick second. We should see PSVs ranging from 110 to 177 centimeters per second. Pretty random number, little number range there. And then after they eat, we want to see that SMA go to a low resistance waveform with a higher diastolic evaluation. So we're going to see kind of like a normal arterial waveform with the preprandial state, and then we kind of see it kind of slow down and get a little bit weaker with that postprandial state. Abnormal postprandial state is if we were to see that waveform still remain high resistance. If we happen to have a stenosis in that SMA, the fasting peak systolic velocity is going to come in at greater than 275 centimeters per second, and at that point, we don't need to do the postprandial. We're not going to torture the patient with that. And then our celiac, normal, low resistance flow. This is not something that we're not gonna evaluate it after they eat because it's not affected by eating. We want to see that peak systolic anywhere from 50 to 160 centimeters per second. If there is a stenosis in that celiac, again, it doesn't matter if it's pre or post eating, it's unaffected. Anything greater than 200 centimeters per second is going to be abnormal. And the IMA, really difficult for us to visualize. If it is easily observed, it could be because it's overcompensating for an occlusion somewhere else. So if the IMA pops out at you, it's like super big, super obvious, that's not normal. So that's probably going to lead us to say that there's some sort of occlusion elsewhere within those mesenteric arteries. This is also something too that when we're doing intra-abdominal or pelvic arterial evaluation, the peak systolic range is not going to be that 125, right? So we're going to see kind of a unique evaluation between the kidneys, between the liver, between the mesenteric arteries. That's not going to be the standard 125 for a stenosis or a question of a stenosis. The 125 centimeters per second for a peak systolic velocity is going to be for peripheral arterial imaging, so carotid, upper extremity arterial arm, lower extremity arterial leg. Anything that's not within the abdomen or the pelvis, we want to use that 125 centimeters per second. Anything within the abdomen or the pelvis is going to be unique to itself. So kind of keep that in mind. Celiac compression syndrome, that's exactly what it sounds like. It's when we have compression of that celiac access by the median arcuate ligament of the diaphragm. So some people have really prominent ligaments in that diaphragm that can kind of push down as the patient breathes and kind of have this intrinsic compression on that access. So it kind of comes and goes with the patient's breathing. It is reversible. We can go in, we can surgically adjust that ligament of the diaphragm so that it's not compressing on the celiac access. But basically, we want to be evaluating for it to see if we can get a diagnosis with it. We're usually going to see high velocity waveforms that can indicate a stenosis in that celiac access. And then when we have deep inspiration, it's really going to lower the velocity. So what happens with the patient's breathing, they take a big breath in and it's going to compress on that celiac access. And it's going to, when you're Dopplering it with that big inspiration, it's going to, wait a minute, I think I wrote the wrong thing on here. Hold on, now I'm having a moment. I'm always having a moment, but hold on. Yeah, okay, I wrote the wrong thing on here. So when we take a big breath in, right, our inspiration, our diaphragm moves down. So as it moves down, that ligament from the diaphragm is compressing on the celiac axis, right? So it's compressing, compressing, compressing. And if we were to Doppler that celiac axis while the patient is taking that big breath in, we're going to get a very high velocity. And that's going to indicate that there's an area of like not normal stenosis. We shouldn't have a stenosis when the patient is breathing or not. When the patient exhales, our diaphragm is going to move back up and it's going to take that compression off the celiac axis. That's going to lower that velocity. So that shouldn't say deep inspiration lowers velocity. Deep inspiration increases velocity. Expiration lowers it and brings it back to normal. Okay, so when you have expiration, it's going to lift that diaphragm and that ligament off the celiac axis. So that those last two bullet points on here, don't read into those too much. It goes from inspiration, diaphragm lowers, right? Our lungs expand, diaphragm lowers, right? Pushes on the celiac axis, causes compression. During inspiration, we're going to have very high velocities because of it, because it's narrowing that celiac axis. When we breathe out, when we have expiration, that ligament's coming off the celiac axis. It's decreasing the velocity in that area. Moving into our liver here, again, very straightforward. This should all be reviewed. You should be performing a lot of these exams in clinic at this point, so you can kind of use this to, you can kind of go over this on your own here. We know that we should be seeing normal flow, and we should be aware of what normal flow looks like in our portal system with the liver. We want to see low velocity, continuous flow. We want anywhere from 20 to 40 centimeters per second. We don't want to see any color filling defects. We want to see a hepatopedal direction, meaning it is going into the liver to feed it. And we don't want to see any varicose veins or vessels surrounding that porta hepatis. You can even pull back up your chart from the spring semester when we learned about all this stuff. Was it the spring? It may have even been your foundations class with that chart. So here we have just our standard anatomic evaluation of our portal system. We know that the liver is very unique in the sense that it uses veins to help supply. We're very used to having arteries supply, but in terms of the portal system, the portohepatic system, we are using our veins. So we know our splenic artery is coming from our spleen, traveling through that pancreas, joining up with the SMV to become our portal splenic confluence, to then become our portal vein entering into the liver. And once it's in through that porta hepatis, it's going to branch off to different segments. Left portal vein is going to go off drastically up towards the left side, and then we're going to have the right portal vein traveling to the right lobe of the liver, and our right portal vein is going to branch into anterior and posterior segments because we know that right lobe is so large. Here on the right hand side, we have our nice Doppler image. We know that we should see continuous waveform because it is still a vein. We're not looking for triphasic versus biphasic versus a peak systolic velocity versus an end diastolic velocity. We're still treating it like a vein, even though this vein has a unique job. It's hepatopedal, it's traveling into the liver, it's traveling closer to the transducer, so it's going to appear red and above the baseline when we Doppler it. Portal hypertension. So one of the main reasons why we do an abdomen with Doppler, especially of the liver, it's usually going to be caused by some sort of prehepatic obstruction in that portal venous system or portohepatic venous system. Could be thrombosis of the portal or the splenic vein, compression of the portal vein, cirrhosis or hepatic fibrosis of that liver tissue, lymphoma in the area of the liver or that porta hepatis, IVC obstruction, which we know could be Budd-Chiari syndrome as well. Same thing, hepatic vein obstruction, that goes along the lines of Budd-Chiari with the IVC obstruction. Complications of having uncontrolled portal hypertension are going to be causing ascites, splenomegaly, gastrointestinal bleeding, jaundice, and hepatic failure. So again, a little bit of a refresher with that. How do we evaluate for portal hypertension? So if we see a portal vein that's like super big and chunky, we want to measure that diameter. If it is greater than 13 millimeters in diameter, that's abnormal. We want to measure that velocity, and we want to be looking at the direction of flow in that portal vein. So if we have a portal vein that's coming in at like 65, 70 centimeters per second, that's abnormal. If it's representing hepatofugal flow, meaning it's traveling out of the liver, that is abnormal. Again, we want to be looking at the branches of the portal vein, so that left portal vein, right portal vein. If we can see the anterior and the posterior branches of the right portal vein, great. We're looking for patency, meaning that they're clear in the direction of those vessels flowing. Also, our spleen. If we see really bizarre splenomegaly, it could be an isolated finding. It could be its own thing, but sometimes when we have splenomegaly or kind of gross splenomegaly, 17 centimeters, 20 centimeters, we know that's going to be abnormal. We also want to rule out compression of the portal vein by any kind of adjacent tumor or mass. So lymphoma, like we said, there's a lot of lymph nodes that kind of hang out in that perihepatic region of where our vessels enter and exit. So kind of in that region of the porta hepatis, we sometimes can get a lot of lymph nodes that are affected in that region. So if we have an abnormally enlarged lymph node from lymphoma, that can cause compression on the portal vein in that area, or any kind of liver mass in that area as well. And then we want to make sure that we're evaluating the IVC and making sure that there's no obstruction or blockage there. The main concern with having an IVC thrombus or obstruction is obviously going to be the risk of embolism or heart attack. Portal hypertension kind of takes a back seat to IVC obstruction or thrombus. Patent umbilical vein. So we kind of talked about this a little bit when we were talking about fetal circulation, and this is very, very important in the developing fetus. But as soon as that baby is born, it's going to close. So the umbilical vein is going to be a branch of the left portal vein. So when we're learning about that fetal circulation, how everything kind of, some of it goes right through the liver, some of it bypasses the liver. If it goes through the liver, it drains through the hepatics, but then it kind of comes out of the liver. It has all these different pathways in fetal circulation, but we don't need it when we are born. So it's going to close. We then reference it as kind of just like the remnant umbilical vein, but it's closed, so it doesn't serve a purpose. Sometimes when a patient has really, really, really high portal hypertension, this is going to reopen. This like distal extension of the left portal vein is going to reopen, and it's going to allow that blood flow to travel out through the liver. So this is when we kind of say it's a recanalized umbilical vein, and it's trying to pull that blood flow out of the liver because the liver is saying, oh my God, there's too much. Like, I have hypertension. There's too much blood happening here, and I can't get rid of it. There's too much blood flow happening, so I need to get some of it out. The pressure is too high. So it pops open that umbilical vein, and it allows that blood flow to come out of it. So we kind of see it as an extension. So here's our portal vein entering. Here's our left portal vein, and then it should stop like here, but then this is reopening. This is the recanalized umbilical vein. It's going to travel down along the patient's abdomen, and it's going to kind of act as a collateral in response to that hypertension. Typically, it's going to be chunky. It's going to kind of look like a superficial varicose vein when we do legs, greater than 3 millimeters in diameter. It's usually going to be hepatofugal flow. It's pulling blood away from that liver. Low resistance continuous flow. So this is abnormal. We don't want to see a recanalized umbilical vein. Even though the umbilical vein is patent, right? Like there's no clot in it. It's kind of representing like normal venous flow. It's still not normal. It shouldn't be open. It's only open in response to some other pathology happening. Tips. So you may have heard of this before. techs don't like performing these exams because we don't do them too often. So they're a little bit challenging in terms of remembering what to do, what not to do, what's normal, what's abnormal, but it's not really anything crazy. If you're comfortable with doing abdomen Dopplers, you just have to know that it's a little bit different from that. So TIP stands for transjugular intrahepatic portosystemic shunt, so quite a mouthful. It's when we place a stent within the liver tissue between the portal vein and the hepatic vein. So we use kind of like certain combinations. Usually we'll go like with the right hepatic vein to the main portal vein. We'll use like each patient on an individual basis where we connect this shunt. The purpose of this is to help relieve compression of the portal venous system. It's not going to address the cause of portal hypertension. So it's going to help with it. It's going to help prevent any further complications coming from portal hypertension, but it's not going to fix it. You're still going to have portal hypertension. It's just not going to be as severe or drastically affecting the liver because we're using this as like a Band-Aid. So we want to make sure we're evaluating for patency, direction, and velocity of flow within the actual shunt itself. So a normal TIPS, a healthy TIPS, we want to see a velocity in the shunt anywhere between 90 to 190 centimeters per second. So it can go pretty fast in that area. The portal vein velocity before it enters the tip itself, before it enters the shunt, should be around 30 centimeters per second, and then it's going to travel a little bit faster in the shunt itself. We're going to see a phasic waveform, so we're still going to see it kind of responding to the patient's breathing. The portal vein branches are going to actually be having reverse flow into the shunt. So the portal vein, the right portal vein and the left portal vein are actually going to drain into the shunt instead of going out to the liver tissue. An abnormal TIPS is when we see color aliasing at the site of where that shunt is placed. Could indicate a stenosis in that TIPS of the shunt. So in the shunt with the TIPS, the velocity within the shunt itself could indicate a stenosis if it's greater than 190 centimeters per second. The velocity of less than 90 centimeters per second is going to indicate that there could be some other kind of distal blockage in that area. A velocity of less than 30 centimeters per second in the portal vein prior to the stent is also going to be considered abnormal. And if there's a complete occlusion, we are not going to see any color evaluation in that shunt. So not something that we're doing very often, but you just have to know that it's kind of like it's a means to an end for portal hypertension where we're basically artificially connecting the portal and the hepatic systems to each other in a more direct way to kind of help alleviate some of that pressure in those distal vessels of the liver. So here we can kind of see the shunt placed right in that. I believe this is probably the right hepatic vein. I think so. I think that's the middle joining together here. I'm not sure. Kind of hard to tell, but we can see that this is going to be that branch of the hepatic. And if we were to follow this kind of cine looping around, we would see it joining back up with that portal, main portal vein in that region of the porta hepatis. Hepatic system anatomy. So when we are doing just a standard abdomen with Doppler, again, refresher here, hepatic veins we know drain into the IVC from the liver, so they're going to display hepatofugal flow out of that liver. Right hepatic vein travels to the right lobe, middle hepatic vein travels between the right and the left hepatic lobes, and the left hepatic vein travels between the medial and the lateral segments of the left lobe. The left and the middle join together before they dump into the IVC in most patients. The hepatic vein diameter is going to increase, of course, as it gets closer to the IVC. It's best visualized when we're doing a transverse subcostal approach of that right lobe, going all the way up towards the top of that liver. Normal flow is going to be phasic and slightly pulsatile. It's also going to be low resistance. So a little refresher with our hepatic system here. Beautiful images. This picture is so nice with the obvious right and the middle and the left that join together prior to emptying into the IVC. And then we can see our pulsatile waveforms with our continuous flow. But Geary syndrome, again, just kind of pulling your attention back to this condition when we're doing liver Dopplers, stenosis or obstruction of the hepatic veins or the IVC can be caused by hepatomegaly, splenomegaly, ascites, can be a conditional thing, but it's pretty emergent, especially when it's affecting the IVC. And then lastly, liver transplants. These are used for end-stage liver disease. We are doing a pre and post-op evaluation using ultrasound to evaluate the patency of the portal veins, hepatic veins, IVC, hepatic arteries, so pretty much all of the standard vessels that we're doing for an abdomen with Doppler anyway. We're also evaluating that liver tissue, making sure that we're not seeing any crazy parenchymal changes. We don't want to see a super hyperechoic liver or a super hypoechoic liver with a liver transplant. And we're looking for those vessels, seeing if there's any thrombus in them as well. Not very common. Again, we're not doing a ton of transplants, especially, pretty prematurely post-op. These are something that surgical offices will have, their own techs or their own physicians performing to make sure that the organs aren't being rejected. Liver transplant is very unfortunate, especially if you were to work at Hasbro. It's something that, as we know, a lot of kids get a lot of liver malignancies, very common in kids for liver malignancies. We've kind of talked about this in the past, but liver transplant lists prioritize patients in a pretty unethical way. And the reason that they do that is, if you have a patient who is a recovering alcoholic, but they have end-stage cirrhosis, their liver is not really going to make it. If you can prove that you have been a recovered alcoholic for, X amount of time, they will place you higher on a transplant list for a liver than a 4-year-old with liver cancer. And their reasoning behind that is, you have a higher likelihood of the patient who is a recovering alcoholic to not have any other kind of liver disease in the future. If you have a 4-year-old who has liver cancer, they have the risk of their entire life they could develop that cancer back again, right? They're automatically at a higher risk of having another malignancy. So it's not right. It's not ethical. It's not fair. But from their point of view, what patient is going to have the highest success rate of that liver not needing to be replaced again in the future? So it's a very inhumane way of looking at things, because for us as compassionate healthcare workers, we want to see the 4-year-old kid with cancer get the liver over, a 50, 60, 70-year-old man who maybe made some poor choices previously in his life. Not to say that that patient does not deserve a liver transplant. They absolutely do. But there's not an empathetic prioritization when it comes to organ transplants. So it's a very heartbreaking but mathematical way that they do these things. So again, this was kind of a recap here, but we did learn some new things about renal artery exams and about mesenteric evaluation. So please make sure, again, you understand that information and that you are refreshing your portal hepatic and your liver anatomy and your vascularity, all of that stuff, because that is something that we are performing quite a bit of. So any questions you can ask.